Start na akong share screen. Nakikita?
Yes po.
So good afternoon. So this afternoon we'll be discussing about shock, taken from Swartz 10th edition chapter 5. So for the overview, shock is the failure to meet metabolic needs of the cell and consequences that ensue. So we have here brief historical background on the topic shock. Wait na wala. Kita na?
Yes, Doc.
Okay, so we have first we have Claude Bernard from the mid-19th century. He suggested that organism attempts to maintain constancy in the internal environment against external forces that attempt to disrupt milieu interior or internal environment. Then we have Walter Cannon. He continued Bernard's observation, introduced the term homeostasis, and he first described fight or flight response. So an organism's ability to survive was related to maintenance and homeostasis. So the failure of physiologic systems to buffer organism against external forces results in organ cellular dysfunction, what is clinically recognized as shock. Then we have Alfred Blalock. He denounced Kahn's theory on shock. So Blalock documented that the shock state in hemorrhage was associated with reduced cardiac output due to volume loss, not toxic factor. So in 1934, he proposed that 4 categories of shock. We have hypovolemic shock, vasogenic shock, cardiogenic shock, neurogenic shock, which led to further classification of shock. So we have here the types of shock. We have hypovolemic shock, septic shock, cardiogenic shock, neurogenic shock, traumatic, and obstructive shock. So we go to the pathophysiology of shock. The initial physiological responses in shock are driven by tissue hypoperfusion and developing cellular energy deficit. So this imbalance between cellular supply and demand leads to neurogenic, neuroendocrine, and inflammatory responses. So the specific responses will differ based on the etiologic shock. For example, in cardiovascular response driven by the sympathetic nervous system, it is markedly blunted in neurogenic or septic shock. So additionally, decreased perfusion may occur as a consequence of cellular activation and dysfunction, such as in septic shock and to a lesser extent, traumatic shock. So in a nutshell, pathways leading to decreased tissue perfusion in shock. So decreased tissue perfusion can result directly from hemorrhage or hypovolemia, cardiac failure, or neurologic injury. Decreased tissue perfusion and cellular injury can then result in immune and inflammatory responses. So alternatively, elaboration of microbial products during infection or release of endogenous cellular products from tissue injury can result in cellular activation to subsequently influence tissue perfusion and the development of shock. So we have the phases of shock. Here, the pathophysiologic responses vary with time and in response to resuscitation. So in hemorrhagic shock, the body can compensate for the initial loss of blood, primarily through the neuroendocrine response to maintain hemodynamics. So we have here the in compensated phase, neuroendocrine response maintain hemodynamics. We also have the compensation phase, which is a microcirculatory dysfunction, parenchymal tissue damage, and inflammatory. And we also have irreversible phase, which is the persistent hyperperfusion results in further hemodynamic derangement and cardiovascular collapse. So we have vicious cycle of shock, microcirculatory dysfunction, parenchymal tissue damage, and inflammatory cell activation can perpetuate hyperperfusion. So ischemia, reperfusion injury will often exacerbate the initial insult. So these effects at the cellular level, if untreated, will lead to compromise of function of organs, thus leading to vicious cycle of shock. So the vicious cycle of shock, regardless of etiology, is decreased tissue perfusion and shock results in feed-forward loop that can exacerbate cellular injury and tissue dysfunction. So we have neuroendocrine and organ-specific responses to hemorrhage. Neuroendocrine responses is to maintain perfusion to the heart and the brain even at the expense of other organ systems. So mechanisms include autonomic control of peripheral tone and cardiac contractility, hormonal response to stress and volume depletion, local microcirculatory mechanisms that are organ-specific and regulate regional blood flow, and in hemorrhagic shock, the magnitude of neuroendocrine response based on both the volume of blood lost and rate at which it is lost. So we have here afferent signals. Afferent impulses transmitted from the periphery are processed within central nervous system and activate the reflective effector responses or efferent impulses. So we have baroreceptor and chemoreceptor. So in baroreceptor, there is volume receptors activated with low volume hemorrhage or mild reduction in right atrial pressure and inhibits induction of ANS. So in baroreceptor, this is a fast-acting BP control. So when you have low or high BP, it will be detected immediately, then normalizes. So kung di rin na kaya, siya nasunod na dito kuan RAS, renin angiotensin aldosterone system. Then we have chemoreceptor. This is sensitive to changes in O2 tension, high hydrogen ion concentration, and carbon dioxide levels. So chemoreceptors na-respond in here to low oxygen levels and high carbon dioxide concentration when the BP is less than, I think, 80 millimeters mercury. Then we have efferent signals. Changes in cardiovascular function, hemorrhagic shock and hypovolemic shock result to the neuroendocrine response and ANS response to shock, and constitute a prominent feature of both the body's adaptive response mechanism and the clinical signs and symptoms of the patient in shock. So hemorrhage here, bleeding, results in diminished venous return to the heart and decreased cardiac output. So this is compensated by the increase in cardiac heart rate and contractility, as well as venous and arterial vasoconstriction. And then sympathetic stimulation of the peripheral circulation via the activation of alpha-1 adrenergic receptors, which vasoconstricts and causes a compensatory increase in systemic vascular resistance and blood pressure, thus induces catecholamine release from the adrenal medulla, which causes the increase in glycogenolysis and gluconeogenesis. So if there is increased glucose na, there will be increased circulating glucose, skeletal glycogenolysis and glucagon release, and there will be decreased insulin release. So we have here the hemodynamic responses to different types of shock. In hypovolemic shock, there is decreased cardiac index with increased vascular resistance. In septic shock naman, there is severe increase in cardiac index and decreased vascular resistance. Cardiogenic shock naman, there is severe decrease in cardiac index and severe increase in vascular resistance. And neurogenic shock, there is increase in cardiac index and decrease in vascular resistance. And then we have hormonal response. Shock stimulates the hypothalamus pituitary adrenal axis, which releases ACTH hormone by the pituitary. So in ACTH, this stimulates the adrenal cortex to release the cortisol. Cortisol naman, this stimulates the gluconeogenesis and insulin resistance. So in setting of severe hypovolemia, ACTH secretion occurs independently of cortisol, negative feedback inhibition. Then we have renin-angiotensin system. So amo na kinayakan kanina. So kung di rin na kaya itong baroreceptor nga i-compensate ito increased or decrease in BP, RAAS occurs. So when there's RAAS, parang nadidetect niya itong low sodium concentration ha blood. So when there is hemorrhage, madidetect maculodensa, itong decreased sodium blood. So mag-release niyan RAAS will release renin then converts angiotensinogen to angiotensin 1, then converts there's conversion by ACE or the to become angiotensin 2, and angiotensin 2 naman amot nag-increase itong BP. Then there is also release in ADH. So may damay kita sinisaring nga where sodium goes, di ba, water follows. So same ini ha bleeding. So if there is bleeding, there will be decrease in sodium. So ma-decrease gap ito in water. So to compensate, there will be secretion of ADH. Secretion of ADH will be released to reabsorb water in the body para di na maginawas itong tubig halawas. So that's the function of ADH. Then we have circulatory homeostasis. We have preload, which is the volume of blood in the ventricle at the end of diastole. Then we have ventricular contraction. The Frank-Starling curve describes the force of ventricular contraction as a function of its preload. So we have afterload. This is the force that resists myocardial work during contraction. And microcirculation naman, there is integral role in regulating cellular perfusion and is significantly influenced in response to shock. Oh, wait lang, nag-text si Doc ko. Okay, so we have cellular hypoperfusion, oxygen debt. There is a deficit in tissue oxygenation over time during shock. So oxygen delivery is limited, water consumption is inadequate to match the metabolic needs. Then we have immune and inflammatory responses. So complex set of interactions between soluble factors and cells that can arise in response to trauma, infection, ischemia, toxic or autoimmune stimuli. So innate and adaptive immune system also works here. Alterations in activity can be responsible for both the development and sequelae of shock. So we have here damage-associated molecular patterns or DAMPs. These are recognized by cells, cell surface receptors to affect intracellular signaling that primes and amplifies the immune response. So here at examples of endogenous damage-associated molecular pattern. And then we have the schema of information of flow between immune cells in early inflammation following tissue injury. So medyo complicated din niya ako ang illustration niya din. But kinukurang gaplin na mag-digest. So kuha na lang ako ang ating libro. Basta na lang kita. So ang pinakanin nga di, pinaka-pointin nga ni cells like neutrophils, macrophage, and lymphocytes, they require multiple inputs and stimuli before they activate a full response. Then we have cytokines. We have pro-inflammatory cytokines and anti-inflammatory cytokines. Examples of pro-inflammatory are interleukins 1, 2, 6, 8, and interferon TGF, TNF, and PAF. Then we have anti-inflammatory, consists of interleukin 4, 10, 13, PGE2, and TGB. So ini nga pro-inflammatory, this induces inflammatory response. Bakat kanin niya, nananawagin, example, leukocyte during an inflammation. So ang mga pro-inflammatory. So ano naman, anti meaning bakat inhibition, gini-inhibit niya ito ang response to inflammation. Then we have complement system. These are activated by injury, shock, and severe infection. This contributes to host defense and pro-inflammatory activation, and complement consumption occurs after hemorrhagic shock. We also have neutrophils. These are the first cells to be recruited to the site of injury. So activated PMNs and their products may also produce cell injury and organ dysfunction. So we have here the forms of shock. First, we have hypovolemic shock or hemorrhagic shock. So these are most common of cause of shock in surgical or trauma patients, which is the loss of circulating volume from hemorrhage. So amon hit na nabuk during hypovolemic shock or hemorrhagic shock. So acute blood loss results in reflexive decreased baroreceptor stimulation from stretched receptors in large arteries, then resulting in decreased inhibition of vasoconstrictor centers of the brainstem, then increased chemoreceptor stimulation of vasomotor centers, and then diminished output from atrial stretch receptors, So this changes in increased vasoconstriction and peripheral arterial resistance. So in continuation, um, hypovolemia here also includes sympathetic stimulation, leading to epinephrine and norepinephrine release. So activation of the RAAS cascade and increased vasopressin release. So peripheral vasoconstriction is prominent, while lack of sympathetic effects on cerebral and coronary vessels and local autoregulation promote maintenance of cardiac and CNS blood flow. So for the diagnosis of shock, this is initially done with empiric treatment. We secure first the airway or establish the volume of infusion initiated while the search for the cause of hypotension is pursued. So shock here in a trauma patient or post-operative patient should be presumed due to hemorrhage until proven otherwise. So we have here the signs of shock evidenced by agitation, cool clamp extremities, tachycardia, weak or absent peripheral pulses, and hypotension. So when a patient is significantly tachycardic or hypotensive, this commonly occurs. This represents significant blood loss, physiologic decompensation. So the clinical and physiologic response to hemorrhage has been classified according to the magnitude of volume loss. So for the treatment naman of hypovolemic shock, this to secure the airway, control the source of blood loss, intravenous resuscitation. So in patients who fail to respond to initial resistive efforts should be assumed to have ongoing active hemorrhage from large vessels and require prompt operative intervention. So actively bleeding patient cannot be resuscitated until control of ongoing hemorrhage is achieved. So for the traumatic shock naman, the systemic response after trauma, combining the effect of soft tissue injury, long bone fractures, and blood loss, is clearly a different physiologic insult than simple hemorrhagic shock. So multiple organ system failure here, including ARDS, develops relatively often in blunt trauma patient, but rarely after pure hemorrhagic shock, such as GI bleeding. So under traumatic shock, we have hyperfusion deficit. These are magnified by pro-inflammatory activation that occurs following the induction of shock. So for the treatment naman, we focus on correction of individual elements to diminish the cascade of pro-inflammatory activation. So this includes prompt control of hemorrhage, adequate volume resuscitation to correct auto death, debrigma of non-viable tissue, stabilization of bone injuries, and appropriate treatment of soft tissue injuries. Next, we have septic shock or vasodilatory shock. This results to dysfunction of endothelium and vasculature secondary to circulating inflammatory mediators and cells or as a response to prolonged and severe hyperperfusion. So in vasodilatory shock, hypotension results from failure of vascular smooth muscle to constrict appropriately. So this is characterized by vasodilation with resultant to hypotension and resistance to treatment with vasopressors. Causes of septic shock and vasodilatory shock. We have systemic response to infection, non-infectious systemic inflammation, pancreatitis, burns, anaphylaxis, acute adrenal insufficiency, prolonged severe hypotension, hemorrhagic shock, cardiogenic shock, cardiopulmonary bypass, metabolic and hypoxic lactic acidosis, and carbon monoxide poisoning. For the diagnosis naman, manifestation of the host response to infection and identification of an offending organism. So when we say shock, the terms sepsis, severe sepsis, and septic shock are used to quantify. Pag-quantify ito ang magnitude of systemic inflammatory reaction. So patients with sepsis have evidence of infection as well as systemic signs of inflammation. Systemic signs of inflammation such as like fever, leukocytosis, and tachycardia. So terms to quantify the magnitude of systemic inflammatory reaction. So amon nga diyan ko ang sepsis, severe sepsis, and septic shock. So in sepsis, there is evidence of an infection as well as systemic signs of inflammation. Severe sepsis naman, there is hypoperfusion with signs of organ dysfunction. While in septic shock naman, there is evidence of tissue hypoperfusion and systemic hypotension plus 2 of the above. For the treatment, assessment of adequacy of their airway and ventilation, fluid resuscitation, and restoration of circulatory volume with balanced salt solutions is essential. Empiric antibiotics must be chosen after carefully based on the most likely pathogens. Long-term empiric broad-spectrum antibiotics should be minimized. Then for the first-line therapy of septic shock, syempre we have antibiotics, IV fluids, intubation, so if it's necessary, and vasopressors may be necessary to treat patients with septic shock. Then we have cardiogenic shock. So this is a circulatory pump failure leading to diminished forward flow and subsequent tissue hypoxia in the setting of adequate intravascular volume. So for the hemodynamic criteria, we have sustained hypertension, reduced cardiac index of less than 2.2 liter per minute per square meter, and elevated pulmonary artery wedge pressure of more than 15 millimeter mercury. So causes of cardiogenic shock, we have acute myocardial infarction, pump failure, mechanical complications, acute mitral regurgitation, acute ventricular septal defect, free wall rupture, pericardial tamponade, arrhythmia, end-stage cardiomyopathy, myocarditis, severe myocardial contusion, left ventricular outflow obstruction, aortic stenosis, hypertrophic obstructive cardiomyopathy, obstruction to left ventricular filling, mitral stenosis, left atrial myosoma, acute mitral regurgitation, acute aortic insufficiency, metabolic, and drug reactions. So cause of cardiogenic shock, acute extensive MI, this is the most common cause of cardiogenic shock. Diagnosis naman, rapid identification of the patient with pump failure, and the ongoing spiral of decreased cardiac output from injury causing increased myocardial oxygen needs that cannot be met, leading to progressive and unremitting cardiac dysfunction. So for the treatment naman, assessment, adequate ventilation, circulation support. So intubation and mechanical ventilation often are required, if only to decrease the work of breathing and facilitate sedation of the patient. Hypokalemia and hypomagnesemia should be corrected. Pain is treated with IV morphine, sulfate, or fentanyl. Then significant dysarrhythmias and block must be treated with antiarrhythmic drugs, placing cardioversion if necessary. Then we have obstructive shock. Causes of obstructive shock are pericardial tamponade, pulmonary embolus, tension pneumothorax, IV obstruction, deep venous under IV obstruction, we have deep venous thrombosis, gravid uterus, and IVC, neoplasm. And then increased intrathoracic pressure. Under it, we have excess positive and expiratory pressure and neoplasm. So, although obstructive shock can be caused by a number of different etiologies, venous obstruction return in patients, this is the most commonly due to presence of tension pneumothorax. So, most common cause of shock, of obstructive shock. For the diagnosis and treatment naman of obstructive shock, classic findings are respiratory distress, hypotension, diminished breath sounds over the hemothorax, hyperresonance to percussion, jugular venous distension, shift of mediastinal structures to the unaffected side with tracheal deviation. For a treatment naman, empiric treatment with pleural decompression is indicated rather than delaying to it for radiographic confirmation. Then we have neurogenic shock. This is a diminished tissue perfusion as a result of loss of vasomotor tone to peripheral arterial beds. So usually, these are secondary to spinal cord injuries from vertebral body fractures of the cervical or high thoracic region that disrupt sympathetic regulation of peripheral vascular tone. So causes of neurogenic shock are spinal cord trauma, spinal cord neoplasm, and spinal or epidural anesthetic. So for the causes naman, causes of neurogenic shock, acute spinal cord injury may result in bradycardia, hypotension, cardiac dysarrhythmias, reduced cardiac output, and decreased peripheral vascular resistance. The severity of the spinal cord injury seems to correlate with magnitude of cardiovascular dysfunction. So for the treatment of neurogenic shock naman, secure airway, adequate ventilation, fluid resuscitation, and restoration of intravascular volume. And administration of vasoconstrictors should be considered once hypovolemia is excluded. Then we have endpoints in resuscitation. So shock, as we all know, is defined as inadequate perfusion to maintain normal organ function. With prolonged anaerobic metabolism, tissue acidosis, and auto death accumulate. So the goal of treatment here is the restoration of adequate organ perfusion and tissue oxygenation. So when can we say that resuscitation is complete? So when there is oxygen death, if there is auto death is repaid, tissue acidosis is corrected, and aerobic metabolism is restored. So for the endpoints in resuscitation, kung kulang na talaga ito in oxygen and endpoints resuscitation, we have here surrogate parameters to estimate the auto death para mabayaran kung saan oxygen. We have systemic or global, tissue specific, and cellular. So systemic, common here are the lactate and base deficit. Lactate is generated by conversion of pyruvate to lactate by lactate dehydrogenase In the setting of insufficient oxygen, base deficit naman, this is the amount of base in millimoles that's required to titrate 1 liter of whole blood to a pH of 7.4. So nga diha tissue specific naman, gastric tonometry is the most common here. Lactate and base deficit indicate global tissue acidosis. Then under cellular, we have membrane potential and adenosine triphosphate. So for the assessment, arterial blood pressure, heart rate, urine output, central venous pressure, and pulmonary artery occlusion pressure are poor indicators of the adequacy of perfusion. So as said earlier, surrogate parameters have been solved to estimate the auto death. We have serum lactate and base deficit have been shown to correlate with auto death. So I think that's all for my lecture today. May ako nagpakita nga video ay
So when we talk about ischemia, we're usually talking about this lack of blood flow to a specific area of tissue. So maybe like with a heart attack, a coronary artery in the heart gets blocked that supplies the left ventricle with blood. So that localized area of heart tissue doesn't get enough blood and oxygen, and that damage is localized to that left ventricle. Shock is like ischemia, but on a global scale. In other words, it's a whole body circulatory failure, where blood flow to tissues is dangerously low, leading to cellular injury, possibly damaging multiple organs, and even leading to multiple organ failure if not treated immediately. Okay, so with shock, the body's tissues aren't getting enough oxygen via the blood, right? Normally, blood perfuses through tissue and delivers oxygen because there's enough pressure in the circulatory system to push it through. So blood pressure is a major determinant for the amount of blood perfusing through tissues. Now, blood pressure is determined by two components: the resistance to blood flow in the blood vessels, things like vessel length, blood viscosity, and vessel diameter, and the cardiac output, which is the volume of blood pumped by the heart through the body per minute. And you can break that into heart rate, the number of beats per minute, times stroke volume, the amount pumped out each beat. Going even further, the stroke volume is found by taking the total volume of blood left over after contraction, the end systolic volume, and subtracting it from the total volume in the heart after filling, the end diastolic volume. Alright, now keeping all those in mind, shock can be caused by a whole bunch of different things, but we can categorize the different types of shock into three main categories, along with some subcategories here and there. The first category is called hypovolemic shock. Hypo means low, vol refers to volume, and emia refers to the blood. So hypovolemic shock is shock induced by a low fluid volume of blood. And this could be either non-hemorrhagic or hemorrhagic. Non-hemorrhagic means that the loss of fluid volume isn't from bleeding. So this could be like if you were stranded in a desert and suffered severe dehydration. Eventually, your loss of fluid and sweat would reduce blood volume to where it wouldn't be enough to supply your body's organs, and you develop hypovolemic shock. Hemorrhagic hypovolemic shock, on the other hand, is loss of blood volume through ruptured blood vessels, in other words, from bleeding. A loss of about 20% of your total blood volume, roughly 1 liter, can be enough to induce hypovolemic shock, and when that liter of blood leaves the circulation, the total volume filling into the heart goes down, meaning the end diastolic volume goes down, right? This means stroke volume goes down as well, which causes cardiac output to go down, and finally we see that blood pressure goes down. When cardiac output goes down, catecholamines like epinephrine and norepinephrine, ADH and angiotensin II are released, all of which cause vasoconstriction of blood vessels, which increases vascular resistance and increases heart rate, which increases cardiac output. And these combined effects all increase blood pressure. A super important indicator of tissues not getting enough oxygen due to hypovolemia is a decreased mixed venous oxygen saturation, or MVO2. MVO2 is the amount of oxygen bound to hemoglobin in blood coming to the right side of the heart from the tissues. So it's like the amount of oxygen left over, or not extracted and used by the tissues. So if blood volume's down, that means oxygen's down, and there's going to be less left over, right? So MVO2 will be down with hypovolemic shock. Since blood flow provides heat to the tissues as well, when it's down, the skin starts to feel cool and clammy, and so hypovolemic shock is considered a cold shock. A second main category of shock is cardiogenic shock. Cardiogenic means produced by the heart, right? So this is when something happens to the heart such that now it can't pump enough blood to the body's tissues. The most common cause is acute myocardial infarction, or heart attack. Hold on a second though. Didn't I say at the beginning that was more along the lines of localized ischemia? Well, the heart attack itself reflects ischemia, right? But these effects of the initial cardiac damage eventually leads to a state of shock. When the heart's muscle cells die, it can't contract as hard, which means the amount of blood pumped out, or stroke volume, goes down, and therefore cardiac output goes down as well. In the same way as with hypovolemic shock, the body releases vasoconstrictors to increase vascular resistance and help maintain blood pressure. Also, as with hypovolemic shock, MVO2 will be down since there's less oxygen being pumped out, and so less will be left over. Sometimes there might be an obstruction that doesn't allow the heart to fill properly with blood. For example, we might have the pericardial sac fill up with fluid from an infection, or blood from a traumatic accident like getting stabbed in the chest. If this sac fills up, it physically constricts the heart from expanding and contracting normally, and also reduces the stroke volume. This is sometimes subclassified as obstructive shock. But you can see that the cause is still due to the heart's inability to do its job, right? Similarly to hypovolemic shock, a reduction in cardiac output leads to lowered blood flow, so the skin gets cool and clammy, and so cardiogenic shock is also considered a kind of cold shock. Alright, the third main category of shock is called distributive shock, where there's typically a leakiness of blood vessels and an excessive amount of arterial vasodilation, or widening of the peripheral blood vessels, which remember is one of the components of vascular resistance. If arterioles dilate, vascular resistance to blood flow goes down and blood pressure goes down, leading to less perfusion and distribution of blood to organs and tissues. Now, the most common type of distributive shock is septic shock, from pathogens in the blood. What happens with septic shock is endotoxins, these large, clunky lipopolysaccharide molecules, sometimes just called LPSs, found in the outer membrane of gram-negative bacteria, causes a crazy cascade of events that ultimately leads to lowered perfusion. First, these guys directly damage endothelial cells and cause them to release vasodilators like nitric oxide. They also activate the complement pathway in the blood, which stimulates mast cell release of histamine, another vasodilator. The LPS molecules also activate immune cells like macrophages and neutrophils, which help create a bunch of pro-inflammatory cytokines like tumor necrosis factor and interleukin-1. These help the immune system destroy the invaders, but they also stimulate the endothelial cells to release more inflammatory molecules like platelet activating factor and reactive oxygen species. All of these inflammatory chemicals damage the endothelial cells and increases their vascular permeability, making the blood vessels leaky. Also, endothelial cells express a procoagulant called tissue factor. Procoagulants are molecules that increase blood coagulation, or blood clotting. And this, in combination with an overall decrease in anticoagulants, which usually decrease clotting and seem to be often depleted or used up during sepsis, leads to this net increase in coagulation and clotting in the microvasculature. And of course, clotting and blockages in the blood vessels further decreases perfusion, right? Okay, so this widespread vasodilation means very little vascular resistance, and blood can't get the chance to unload as much oxygen as it cruises through the vasculature, and it gets back to the right side of the heart with leftover oxygen. So in this case, as opposed to cardiogenic and hypovolemic shock, MVO2 can be normal or even increased. In contrast to hypovolemic and cardiogenic shock, now there's an increase in flow in the peripheral blood vessels, and the skin becomes warm and flushed. So distributive shock is a kind of warm shock. The overall combined effects of widespread vasodilation, increased vascular permeability, and microvascular blood clotting all contribute to decreased perfusion of blood to vital organs. Now, two kind of subtypes of distributive shock are anaphylactic shock, which is an allergic reaction that causes dangerously low blood pressure, and neurogenic shock, where the nervous system gets damaged and can't control the body's blood pressure.
The treatment of shock depends on the cause. In general, the goal is to stabilize blood pressure so that vital organs like the heart and the brain are perfused with blood. In order to stabilize blood pressure, fluid replacement and medications that increase heart contractility, cause vasoconstriction, and retain fluid can be administered. Oftentimes, a person might need supplemental oxygen or have their airway protected, for example with intubation. All right, as a quick recap, shock is ultimately a failure in tissue perfusion, and it affects the whole body, putting tissues and organs at risk for injury and ultimately organ failure. Hypovolemic shock happens when dehydration or hemorrhage reduces the volume of blood in the blood vessels. Cardiogenic shock happens when a direct injury like a heart attack or an obstruction like a pericardial effusion prevents the heart from pumping blood efficiently. Distributive shock happens when something like an allergic reaction or damage to the nervous system, called neurogenic shock, causes the blood vessels to vasodilate and become leaky, which reduces the resistance and lowers the blood pressure.
So that ends my report. Thank you. What time is your exam?
Thank you, Paul.
Pardon?
Thank you, Paul.